Welcome everyone to today's webinar on evolution of IT systems to support innovation in health services delivery, sponsored by Lenovo Health and Intel. I am Maggie Moran with Becker's Hospital Review. We will begin today's webinar with a presentation and we'll have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. We are looking forward to hearing your questions. Additionally, in about a week following the webinar, we will be sending you a copy of the presentation to the email you used to register. At this time, it is now my pleasure to start today's webinar by introducing our panelists. Dr. Bruce Metz is currently Vice President and Chief Information Officer for University of Connecticut Health Center, a leading academic medical center. Dr. Metz has an extensive track record encompassing over 25 years as CIO for prominent institutions in healthcare and higher education, including Lahey Health, Thomas Jefferson University, and Jefferson University Physicians, and Tufts University. Chuck Podesta has over 30 years experience in information technology for healthcare, the last 18 years as a Chief Information Officer. He has worked for academic medical centers, health systems, and community hospitals. He is currently the CIO for University of California, Irvine Health. Previous to this engagement, Chuck was SVP and CIO of Fletcher Allen Healthcare, a large academic medical center and health system in Burlington, Vermont. Wyatt Yelverton is a specialist in emerging and mobile technologies such as augmented reality, AI, and IoT in healthcare. Principal among his initiatives is the development of applications and practice models that enable highly personalized and effective care at a distance. He brings a diverse background of administrative, clinical, and IT leadership experience, having held ambulatory leadership and management positions at regionally and nationally regarded provider organizations before joining Lenovo. During today's webinar, we'll be hearing from Dr. Metz and Chuck on how their prominent healthcare organizations are taking technology to the next level to improve quality outcomes both inside and outside hospital walls. Wyatt will also offer a commentary on how emerging IT innovations are transforming the future of care and what game-changing developments we can anticipate. Finally, we are pleased to have Scott Becker, publisher of Becker's Healthcare, here to moderate today's discussion. Scott, I'll now turn the floor over to you to begin today's presentation.
Thank you very much. I'll just talk through 3 or 4 housekeeping notes to get us started. We'll have about 40 to 45 minutes of presentation, and it'll be divided where Dr. Metz speaks for about 20 minutes in the Q&A form on innovations and how they've developed innovations and IT to support that. And then Chuck Podesta will do something similar for about 20 minutes, talk about innovations and what they've done to support innovation through IT systems and so forth. Then Wyatt will join us for some discussion, and then we'll move to Q&A from the audience. So I would encourage our audience at any time to enter a question in, and we'll try and get through as many of those as we can in the last 15 minutes of the session. Thank you all for joining us, and let's get started with that. Dr. Metz, welcome, and we're going to start with you. I know we've got about 6, 7 questions for you, but you're going to start with an overall introduction of an innovation that you've worked on and probably give us several minutes on that. Are you ready to go, Dr. Metz?
I am, Scott. Thank you for that opening question. I'm delighted to be on today's panel. So let me start just by providing just a brief context and background with University of Connecticut Health Center, also we call UConn Health. As an academic medical center, UConn Health has innovation as an integral part of our DNA. So for example, whenever a significant problem or area of inquiry is presented, we do not have a shortage of ideas or potential innovative solutions. In fact, our challenge is often how do we prioritize different approaches and ideas and leverage what happens at a local level in order to get innovation at the organization level to really transform the care that we're providing, and then as the premier academic medical center for the state, leverage that so that we could capitalize that statewide and now with other partners that we have even beyond. So let me give you a prime example that we're currently working on in the area of e-health and telemedicine. UConn Health has a long-standing interest in those areas, and actually dating back for even 10 years or so, just about every clinical department in our organization has engaged in some form of telemedicine activity even before it was really mainstream, either as a direct part of their clinical practice in primary care or in a specialty area, or as part of a research study, and perhaps in collaboration with one of our centers of excellence, a consortium, or even a statewide group. And some of these activities, to give you a flavor for what went on over the last decade, included e-visits, electronic consults or e-consults, as well as really some targeted mobile applications that specialty areas like cardiology and endocrinology would develop. And we were really aiming not only to enhance the patient experience for provider-to-patient interactions, but because we really have a cadre of high-end specialists, and the state of Connecticut really had a need for e-consults in the provider-to-provider area where we made our specialists available. The issue that we had was that almost all of these telemedicine activities were initiated locally, either by a particular department or research group, and so they were either funded locally or through research grants. And so although there was a great deal of success that was enjoyed, many of the projects ran into issues when that funding would run out. And so sustainability became a problem, and also because the technology was chosen locally, it wasn't quite what we would call enterprise grade, so scaling the effort beyond the targeted initial patient or provider population became very difficult. So let me just give you one really prime example that really illustrates that UConn Health entered into a partnership with a federally funded qualified health center in Connecticut, which allowed for payment of medical diagnosis e-consults for Medicaid patients. And so for over a 2-year period, there were on average 500 to 600 video e-consults that were performed with a number of our specialty departments, psychiatry, orthopedics, dermatology, and endocrinology, to name a few, with really, and we measured success in terms of reduced time for access, provider and patient satisfactions, reduced ED visits for the chronically ill that had more physician access due to the frequency of the e-consults, and all of those metrics were incredibly positive, metrics that we'll continue to use today. However, what happened was that as the funding wound down, that the reimbursement rate got cut in half, which really impacted our physicians' ability to participate, and the technology got old. So although the program was successful, it kind of drifted away. So we've really incorporated all the lessons learned out of that, and our innovation that I'll talk about here is we are really reinvigorating all of the successes and e-health telemedicine initiatives that UConn Health enjoyed over the past decade, and recast those with a new industrial strength enterprise-wide technology platform that I can talk about in a second, but do that within an enterprise strategy and provide institutional support in terms of resources and other items that would be needed to sustain and scale programs like that. Fortunately, the cadre of physicians and researchers that were so enthusiastic about really being pioneers in the telemedicine and e-health field a decade or so ago are still equally enthusiastic. So they are all really engaged in putting together an enterprise strategy, and that we can talk about later, that technology is critical, but by no means sufficient. So we have much more of a formal steering committee and governance structure and other organizational mechanisms to ensure that there's adequate support, not only today, but on an ongoing basis. And we're really excited to be kicking that off. And as I mentioned, our focus is going to be around providing specialty and subspecialty to primary care physicians, not just within UConn Health, but throughout the state, to kind of reinvigorate the positive outcomes that we had before in terms of much better access, much better outcomes, and hopefully lower cost of care. I should note, particularly also in dealing with underserved populations, which we're very dedicated to in the Medicaid arena, saving patients the time and the cost of transportations is really significant. And that will be one way that we really measure our success, that patients report those kind of outcomes and that kind of satisfaction. Really interesting too, when we did an inventory of these past efforts to see how we would prioritize what we would do going forward, we began to look into UConn Health's education mission. And there was telemedicine type activities that were going on there for a number of years, which included grand rounds between students, residents, and physicians, not just here, but in partner hospitals and health systems that we work with. Cancer evaluation, tumor boards that had experts consulting remotely via video, and also there was an ongoing remote observation of surgeries that our students partake in. And the technology infrastructure that was developed for that was really what I would call enterprise and industrial grade. So the investment that we need to make to really reinvigorate and expand our innovative e-health program is now great, because we could actually utilize and leverage the technology infrastructure that is built and maintained for the activities I just mentioned that are going on in our educational arena. So, we're very excited about where we're going with this, which is really, happy to talk about more in the other questions, really part of our overall digital health strategy to help transform healthcare using technology to improve health and produce better outcomes.
Thank you, Bruce, very, very much. So the big effort is sort of remote care, e-care, digital care, trying to treat patients where they are and become much more efficient in doing so. What kind of hardware, software applications needed to help support this? Just a few examples of what kind of, what do you need to support? You've talked some about that, but just to give us a few core thoughts on that.
Sure. Yeah, happy to, Scott. So the basic support really starts with a strong foundation that comes typically with an organization deploying a robust electronic health record. Because in order to do that, one really has to revamp the IT infrastructure to make that work, since part of, at least in our case, and usually for other organizations, the EHR ecosystems involves a patient portal. And so that extends the care already. And so the networking infrastructure, the core server infrastructure, the kind of end user devices that are needed, the plumbing that's needed to make mobile applications work and communicate in concert with the core EHR are all put in place. And so the incremental investment to do it, you just described well, Scott, to extend other capabilities like e-consults, e-visits, remote patient monitoring, patient education tools, a patient engagement platform where patients, particularly with chronic illness, can communicate with care management and care advisors on an as-needed basis, and communicate with their provider on an as-needed basis. Most of that infrastructure is already there. And so what's typically needed is to extend that perhaps with some more mobile devices, either a smartphone or a tablet or an iPad, and also then to begin to utilize some of the, if you're going to start developing your own application, some of the industry standard APIs and other software mechanisms that are there to extend the capabilities of an EHR, and that gets back to having developers and resources. So, there's a variety of items that are needed, but if the foundation is done right, which centered around the EHR, that incremental investment should be manageable for most organizations, but it's really making sure that that 24/7 support comes along with it. So it becomes a real balancing, and so the people human element becomes absolutely critical in addition to the technology.
Sure. So I heard you say 3 or 4 things. Great foundation in place in terms of the EHR and a number of other things. Also, that a lot of this is not just technology, but it's support behind that technology, service to work through things and so forth. And if you have both those things, great service and great foundation, you could do a lot of this extension in a rational way. And that's sort of what I heard you say.
Absolutely. Yeah, right. And it also is really important to have a strategy and make sure, because there's so many different ways that an organization can do this now. As I mentioned, we have thousands of ideas of what to do literally, that it really becomes important to set the priorities and align the initiatives that the organization wants to undertake with what are the strategic objectives that the enterprise has. Is it to generate revenue? Is it to increase market share? Is it to better serve underserved groups? Are there physician shortages that an organization needs to make up because of their geography? So it's really important to align those activities with where the organization wants to go.
No, I think that's a great point, to really understand the purpose and why you're doing it. Because if not, you can get caught in a bunch of different directions and spend a crazy amount of money without clarity of what you're really trying to accomplish. And we're going to get to a couple questions about that in a second. So let me ask you two questions sort of together. The first has been, since you've pushed further into this innovative area or this innovation, in this case, e-visits, electronic visits, and so forth, what's the impact been on your patients, on your staff, on your knowledge workers? And then sort of connected to that, how do you look at the ROI on this? How do you sort of measure your goals and whether you're meeting your goals? And let me sort of have you tackle those two questions, and I've got a couple more questions for you. Then we'll get to Chuck Podesta on some of the questions we have for him.
Sure. Yeah. Another great question, Scott. So for patients or consumers, I think that's pretty easy. I think part of what's driving the transformation of healthcare, in addition to all these changing payment models and advances in technology, is the demands that consumers, our patients, are placing on us and all of the providers and health systems and other key stakeholders in the healthcare industry. I mean, patients expect to have the same level of activity and service that they have in other parts of their life, where health care becomes much more convenient, that they can get the care they need when they need it locally, when they want it. They can get access to their information when they need it. I mean, electronic health record, the data in there belongs to the patient, and so they have every right to expect that they have easy access to schedule appointments. It is easy to get the kind of patient aids and information about what's going on, discharge planning and things like that. Patients rightfully expect that.
Sure.
We will be able to provide that to them. So anything that we can do in that arena is a real positive. And for example, when Yukon Health rolled out the EHR and really introduced a much better portal, the reaction of our patients, like other organizations, was really positive, because that provided a lot of the capabilities I just mentioned.
And how do you measure
the issue with the, have we measured it? Well, one is, the patient satisfaction is a big measure. Physician satisfaction and provider satisfaction for us is another big measure. But, we also look at a host of key performance indicators about how our organization is performing. So things like, for the areas of e-health that I mentioned, is that the time it would take for a referral or an e-consult to occur. I mean, there are industry standard metrics and benchmark for that, and we track that. And the value of going to an electronic form is we should be able to reduce that. And we also measure things like patient outcomes. So what I referred to before, we'll keep track of patients with chronic disease and like the comorbidities, is that when we start engaging in e-visits and e-consults, do we actually improve the outcome so there are less ED visits, less hospital readmissions? There's a number of metrics like that that we would use. So how we look at it runs a wide gamut.
Great. Let me ask you one more question. Then I'm going to move to Chuck and come back to you in a little bit. In 30 to 60 seconds, what are the top lessons that you'd like to share with others? You know, what are the 2 to 3 things that, as you think about what you've accomplished, and I heard some of them, that are fundamental that others ought to think about as they engage in innovative ideas, growing the way they do business, changing the ways they do business in the IT to support that? What are a few core ideas for you?
Well, I think that I'd put at the top or near the top of the list has to do with the whole area of innovation, because we've talked about some of the technology, but really to have successful innovation at an organizational level, it's much more than the technology, and I would consider an interplay of 4 key areas: the people involved, and we didn't talk much about it, but you mentioned knowledge workers and others who have to be involved in all this, the culture of the organization, a strategy and a plan, and the technology. And of all those 4, the ones that are typically not given as much attention as deserved are the people and the culture. And of the 4 I mentioned, the ones that are the biggest determinants of success and the outcome are the people and the culture. So I would encourage to really look at all 4, but not forget about the importance of considering how people and culture are factored into any innovative initiative. The other kind of related lesson I would say is it's very easy to be tempted to boil the ocean, because once you stimulate interest and engagement on the part of members of an organization, you can come out with a lot of ideas, and you can't do all of them. So one needs to be really careful about how to prioritize and do what I referred to before, which is kind of align the objectives in the project with what the primary organizational goals are about in order to get the value that's needed to keep the effort sustaining. I would put those 2 at the top of the list.
You said a number of things. People and culture, fundamental. You've also said something that you sort of talked about a little bit earlier, just absolutely core as to what is the strategy, what's the purpose of what we're trying to do. We're trying to expand our market share, we're trying to reduce costs, we're trying to reduce ER visits. What's exactly the purpose of the effort? And I think that's such an important point that is sometimes not talked about enough. So thank you very much. With that, Dr.
Thanks,
Metz,
my pleasure.
Let me turn to Chuck for about 20 minutes, and we're going to come back to you, Chuck and Wyatt. Chuck, if you're ready to go, a few minutes on an innovation that you've implemented at your organization, and then we'll go through a series of questions to how you supported that and thought about that and so forth.
So absolutely. So thank you, Scott. So again, my name is Chuck Podesta. I'm the CIO at UCI Health, and we're actually, if you know UCI Health, we're part of the University of California system. And as part of that system, we're aligned with UC San Diego, UCLA, UC San Francisco, and UC Davis. So the 5 CIOs we get together on a regular basis and work together on leveraging our scale for value. When I got here, our journey actually started about 4 years ago. When I got here, we were the only one of the 5 that had a different electronic health record than the other 4. And so that was a problem when you're trying to leverage our scale for value, and we're the outlier from an EHR perspective when you're trying to do research and analytics and all the other things, best practices around care delivery, makes it very difficult. So I knew right away that we needed to move, and it was the other 4, by the way, of Epic. So our journey started there. Now, implementing an EHR is not necessarily, everybody has done it now, some more than once. And so that's not necessarily unique or innovative, but how we did it, we actually went out and did a scorecarding process of the other 4, because rather than going directly to Epic for the foundation model, we did a cost analysis that said basically if we could take one of our other partners here and utilize their build in some way, stick to an 80-20 type of approach, accept 80% of the build, change 20% of it, that we could actually save a significant amount of money in the range of, $35 to $40 million. So that drove us to kind of look at which one of the four makes the best fit. And as Dr. Metz said, culture and people became a really big part of the scorecarding, because we wanted to make sure if we were going to align ourselves on an instance of Epic with another organization, we were going to be working very closely together with that organization. So we actually went through that scorecarding process. It was kind of like speed dating, and we ended up with UC San Diego, both from a geography standpoint. Their size was closer to ours, and the culture and people as well. So we went down through that path. We implemented it, and it came. At first it was really a cost type of initiative. Saving that money was huge for us, but as we started to implement it, and other things started happening, our IT department certainly were working closer together on that instance, and we started looking at, should we start to combine our IT departments in some way, whether that's shared management in some way, joint services, purchase services, all these kind of things started to come into play in parallel with the implementation itself, which, when you think about it, it's significant more savings that you can find, especially on the OpEx side, because you're not talking about a capital project at this point. You're talking about how you're going to support the system, once you go live. And so it was very interesting. There's no cookbook, approach that. Epic really didn't have anything as well, because it really wasn't a connect project. It was two kind of equal-sized organizations coming together. We both are academic medical centers, so we have two large, medical practices that needed to work together. Things like shared governance you had to implement, which is can be fairly difficult. And what we found is, as the CEOs, as part of the executive sponsorship, they started to look at other things like pop health and telehealth and other things that we should be working together on, since we're going to be on the same EHR, and moving into other parts of Southern California, instead of doing that individually, doing that together as an organization. So it really spurred a kind of a cooperation that even in an M&A you don't really see, and it usually takes years to do. We did the implementation in 17 months. We've been live for a year now, and we're working very closely together from an IT perspective on a joint services, purchase services model, where we purchase, project managers from each other. We do some shared management between both organizations as well. Then we pay for 50% of that manager instead of the 100%. So we're looking at, savings in the range of anywhere from, $10 to $15 million per year in the direction that we're going right now. So very different model. As when people implement EHRs, there's usually a big bump in the cost post live, and then sometimes it ends up in the newspaper, and we all know some of those, and maybe some of the people on the line here work for some of those organizations that had issues with the AR, or had to add a bunch of resources post live that end up on the OpEx versus CapEx, and that becomes an issue, a board issue at some point. So we have to avoid all that here, based on really coming together and leveraging each other. And so I'll stop here. I mean, the future is bright, for us, because now it's kind of 1 + 1 = 4 from a math perspective on what we're doing. And from a cost, it's, 1 + 1 = 0.5. So we've kind of hit both those markers, and we're pretty excited about it.
Fabulous. So let me ask you a question. In terms of putting together the organizations, you made a strategic choice that, rather than sort of going back to Epic and saying to Epic, you tell us how to solve this problem and what to do, you first used your own leadership to say, let's take a look at what the other 4 systems are doing, or health systems are doing, and see what's working best, and let's sort of piggyback off of that. Chuck, do I have that kind of right?
Yeah, and we, it's kind of a little bit of what was Dr. Metz was talking about when you looked at people and culture as well, and the size of the organizations. We're very close to UCLA, so you would think, we even share a patient population. So you think, we should join with them, but they're just so large, and the way they do things, we did not want to be absorbed, by another organization. We wanted to be partners. And I remember a meeting with them, and I joke with the CIO at UCLA about this, so I'm not speaking out of school here, but I remember a meeting we had with them when we were talking about shared governance, and that was an important part of what we needed to do here because we wanted to be co-equals and not just be connect. And I remember sitting in the meeting, and the person said, "Well, if you take the word shared off, then we got a deal." And I was like, "Well, yeah, that's not going to work for us." So that's why, to me, it was more about that people and culture than really anything about their build was better than another organization's or anything like that, or their technology was better, that sort of thing. It was, can we coexist with each other moving forward?
Sure. And so let me ask you a number of questions sort of in this interconnectedness and a fascinating comment you made about shared versus one party being subordinate to the other party and that being sort of a deal breaker in your discussions with one institution. Fascinating commentary and sensible. What kind of information technology needed to support what you did here in terms of intersecting these different systems and trying to find ways to work together? What software, hardware applications, how did that work? And since you've gone live, you did your whole go live or implementation in about 17 months, and that's sort of a different kind of go live than we typically talk about, but really the same impact. What's the impact been on patients, on your staff, knowledge workers? So the first question, what kind of software, hardware, applications needed? Two is implications for your team, for your staff, your patients, and others.
Sure. So, right away, what it allowed us to do on the technology side was that San Diego, they did not have an enterprise license. They were what called a la carte. So they were buying modules as they needed them. Well, to go enterprise was very, very expensive, but by adding us into the mix and us splitting the cost, we were both able to do enterprise licensing. So right off the bat, both of us in San Diego, we had a benefit of coming together. The next thing we did was we decided that, our data centers are, we all want to get out of the data center business, and we all have cloud strategies. And this was a big opportunity for us to take the system and move it to Epic, and that's what we did. Epic hosts us, both of us, on that single instance, and that's been a godsend. We've been doing that for about a year and a half now, and it's working great. So that's part of our cloud strategy. It's a private cloud, but at least we're moving out of our data centers. So that's been a huge impact for us on the technology side. And the other thing that we saw as well is, the EHR is just not Epic. It's all the different systems that it interacts with. And so we started to align ourselves on, whether it was document imaging and some of these other systems, and really either, UCI changing our system to San Diego's interface engines, things like that, or vice versa. And we also looked at, was really interesting during the implementation, best practice. We decided on guiding principles, and one of them was that we would accept the build of San Diego, hopefully that following that 80-20 rule that I mentioned. But if there was a best practice at UCI or any of the other UCs that we could use, that San Diego would then change their build because they would want to use that best practice and then give it back to us. And that was huge, because there are things that the clinicians deemed that we did better, pain management, our care plans were better, things like that they then San Diego aligned themselves on and then gave it back to us in their build. So from that standpoint, it was big. So on the from the patients and staff, go ahead.
Let me stop you for 1 second there. How hard is it amongst a couple different systems for a system to admit you're doing that better than we are, or on this area we're doing it better than you? How hard is that culturally, people-wise, to sort of manage through those kinds of issues?
It was very difficult to start with, because you can imagine these organizations haven't worked together very much. I mean, they may the physicians may know the physicians at San Diego and vice versa. Some, but they haven't really worked together on a project like this. So what we did was we actually did a faculty summit, and we brought all the faculty together on a Saturday, fed them, and sat cardiologists with cardiologists, and just started. How do you guys and gals want to participate in this project? And they're the ones who kind of came up with, we can really learn from each other and help each other. And they're the ones that actually came up with, we should have that in our guiding principles, that, we know we do certain things. And they kind of have that feeling because in the UC system, that, dermatology at UC San Francisco, they've got a tremendous program and a great build. Let's grab that, So they kind of word of mouth, they already have that kind of idea. But yeah, at first it's difficult because you can imagine, we're going on to San Diego system, and of course they're going to be, hey, we're the best, we're the brightest, we're epic, we know what we're doing, so just take what we have. So it took a little while, but once we had one win, and we showed that win where UCI had a better a best practice in a certain area, then the gates just opened up.
Fascinating, and thank you. How do you sort of measure ROI on some of these efforts? Is it easy to measure cost benefits? How do you measure some of that? Let me ask you that question.
Sure. Well, we know we saved $35 million, but because we implemented in a shorter period of time, so you're using less consultants, less, your monthly burn rate. We did all the analysis on that. We hit our live date, so we know we saved that kind of money right off the bat. We know we're saving money on the support side because we're working together, and we can calculate that as well. We also know that, we didn't have the bumps in AR and things like that because we're on a system that works. And if you adopt some of the workflows in, say, the revenue cycle area, you go live, you're getting bills out the door right away. And so from that perspective, we didn't have that bump. So, there's a bunch of metrics that we were looking at that in a traditional EHR implementation, you would think you would have issues with, and we didn't see as many of those.
And how often are you discussing the ROI, sort of what the CIO's department, what health IT or IT saved or helped improve? How often are you having that discussion with your CEO or your leadership or board? How much a part of that discussion is there in your organization?
It's weekly, basically. I mean, because right now we're doing a double upgrade. We went live on 2015. On December 8th, we both go live on 2018. So we call it a double upgrade. We're working on that together. It's a big project. It requires training. We've been 6 months into it. Both organizations have to work together. It's not as big as an implementation, certainly, but it's right up there, and it's only a year after we've gone live. So our executive leadership are very much involved, and in the meantime, we're optimizing still, especially on the ambulatory side.
It's sort of focused both on both money saved and, more importantly, or as importantly, not having hiccups.
Correct. It's a risk, kind of a risk adverse, process. We know, we're doing the double upgrade on December 8th. We have, it's both organizations, but it's a single database. But we have both organizations that will help each other out if there's an issue in either of the organizations.
You feel you've got some redundancy there too if there's problems, because you have a couple different teams and organizations that can help each other, which is greatly helpful, which most systems don't have, or many don't have.
Exactly. We're leveraging that scale, right? So we have two organizations. We have two sets of physicians, groups that we can leverage them back and forth. We have nursing, we have two of everything. So, and they work very closely together because of the shared governance and, big projects like nurse triage and things like that. We need to decide to do those together. So nursing has to be talking to nursing, docs to docs, and you build that relationship over time.
One more quick question, because I don't want to get to Wyeth as well in the group of you. And I'll ask you really two questions. First question is, and it's somewhat facetious, is when you show the $35 million in savings, how long does that halo effect last for? Does that last for a week, a month, or then do you have to keep on showing savings?
No, what happened was, it was interesting because, after we went live, of course, you do have some issues. We had some training, retraining that we had to do, but the way we looked at it was we had $35 million in savings. So if we needed to dip into that to accelerate, stabilization of the system and things, that's what we did.
And that was a normal investment given the savings you did on the front end, and that makes a lot of sense. It gave you more. As long as the things are performing well, it gave you some more room to run and improve what you had to improve, to add resources to do it.
Right. Instead of saying that, now we're over budget on the project. Our budget was $100 million, and now we're going to spend, $120 million. Well, we had a $35 million savings on our budget. So if we had to dip into that savings post-live for doing some targeted, support things, it didn't cause a lot of consternation in the organization because of that. So that was helpful.
And so let me ask you one other question, just very quick, 30 seconds. Top lesson for somebody else listening in who's, trying to deploy IT or encourage innovation with their system from a technology perspective.
Well, I think, it's with all the M&A activity going on and especially in urban areas, you get a lot of organizations, start working together with them. And even if you're in a competitive mode, it doesn't mean from an IT perspective that you can't start looking at joint services with other organizations, even if they're not part of your system. You can make this stuff work and drive down we're talking about driving down the cost of healthcare. Well, this is one way to do it. And you can show savings to each organization. We put together a program that showed if we started combining our work, we could save $15 million a year and split that between both organizations. If you start doing that, you get the CFO and CEO's attention, because we're always asking for more money. This is the way we're actually saying if we come together in a certain way, that we can actually save money. So it's a totally different concept.
No, thank you so much, and it's fascinating. It's like what you're saying about always having to ask for money is so true throughout IT and throughout healthcare IT, and so it's a constant necessity. So if you could offset it with big, smart things that help offset some of that cost, I'm sure it's very welcome. Wyatt, let me ask you to take a moment, introduce yourself again, and then I'd love to ask you a couple questions too to get some of your input, because you see this across a number of systems and a number of large health centers. Wyatt, I'm going to ask you the question, and as you start the question, I'm going to ask you to just, again, introduce yourself. How do you see technology evolving to support continued innovation? And then I'm going to ask you, how do you keep pace with the need to provide technology that meets the demand for healthcare innovation? Wyatt, can you follow that?
Yeah, for sure. So,
thank you.
My role and my objective, especially as part of Lenovo, is to really be able to go out and understand very much what the environment is doing, how different organizations are responding to trends, how we as an organization and then as an industry can help support some of those trends. So Lenovo overall has a dedication to healthcare, which goes really far beyond the focus on the technology itself to actually go and attempt to solve problems with respect to health service delivery, to the organizations, and to the people who are involved in that, whether they are the providers, the patients, familial caregivers, or many of the ancillary service providers as well. And kind of overall where we see technology evolving is in many ways hitting on a couple of the topics that we've already spoken about today. In particular, mobility is a huge point of focus, especially with respect to how we can embrace this concept of value delivery, how we're able to engage patients, how we're able to keep them inside of our organizations, and be able to simultaneously improve our lines of business, our revenue opportunities, and the overall market opportunity for our organizations. Mobility really becomes a principal focus for investment, for innovation, for new lines of discovery. In particular, we mentioned several times the focus around telehealth and mobile consult outside of a facility-based environment. really with the increase in opportunity provided by wearables, with analytics, with AI technologies that actually are able to communicate with patients, we see an opportunity to actually move away from consult-based e-care into an asynchronous platform. Really, this then improves our opportunity for engaging patients when we don't necessarily have a resource available. We're able to answer questions without the involvement of a nurse or a physician, and we're able to keep a closer eye on the patient, such that when we do need to intervene in that patient's care, we're not only doing so very precisely, but we're doing so effectively with respect to that patient's needs. Simultaneously, we're seeing, just an expectation that the technology has greater flexibility and greater applicability. The same technologies are touching more users, and in particular, especially from a physician as well as a provider perspective, users are coming into our environments expecting that they can apply the same technologies, the same techniques that they would in their daily lives. And that's having a very significant influence, not only necessarily on the devices themselves and the user interfaces, but then how those systems interact with each other.
Wyatt, how do you, in your role, you're working with a ton of different hospitals and health systems, how do you sort of keep track of the need and the pace at which you need to change at Lenovo to help handle these things, like the move towards wearables, the move towards, as you mentioned, patients, clinicians, everybody sees that technology in their daily life and now wants to make sure on their job or as a patient they're getting the same benefits of that kind of technology. How do you sort of track that or keep pace? What kind of things do you do to help systems keep pace with that really rapid change in what people are expecting as patients and as clinicians?
One of the most significant ways is just being involved at the provider level. Quite significantly, the value of Lenovo having a healthcare-focused organization is that we are able to have a much greater level of contact and of specificity of communications and conversations around the needs of healthcare organizations, and to be able to build that out to specifically create solutions that address the unique needs, the individualization and specialty of those organizations. So ultimately, I think the value of what we're able to bring to the table relies principally on that openness of communication and of the pure analysis of what the challenges are facing healthcare organizations and the building of partner relationships such that we are originating technologies, techniques, methodologies, engagement capabilities that are driven by provider and health systems needs rather than pure technology platforms.
Gotcha. So really, you have to be very much in sync with provider systems and talking to provider systems and really in touch with them to be able to anticipate and see what they need. I mean, rather than building it in a vacuum.
Yep, absolutely. And that improves not only the engagement of those organizations, but improves the opportunity for effectiveness of those systems as well. Whereas instead of having an organization come to us and say, well, what's best practice around that particular technology, we can do it in a consultative type fashion, much like Chuck was mentioning in their implementation of Epic, such that similar organizations, similar requirements can build and grow off of each other, and that we can develop our systems to support and maintain that.
Let me do this, Wyatt and Bruce and Chuck, Dr. Metz. We've got great questions from the audience. I want to try a couple things with the questions just to manage time. I'm going to start with a question. I'm going to ask Bruce to comment on it for about 30 seconds, the same with Chuck, the same with Wyatt. And of course, any question could be a 20-minute question or a multi-day question, but I'm going to try and push you to limit your answer to 30, 45 seconds. And so it'll be your quick thoughts on this. Bruce, let me start with you. The decision maker for technology spend, and I know it will depend on technology, but give us a couple examples. Who's the core decision maker? Is it the IT department? Is it a clinical leadership person? Is it the CEO? Is it the CFO? Who decides on whether to adopt new technology in an area?
The quick answer to that, Scott, is it depends. It depends on what the technology is and what the overall cost is. typically infrastructure items, I would be the decision maker with my team in consultation with other stakeholders that I need to bring in. But those that affect the business, some of those are driven by the business. Others we would really process through our governance structure, and depending on the level of spending, our board can get involved.
Gotcha. So it ends up being a $10 million plus. The board's getting involved. If it's infrastructure, it's going through you up to some number where you're making decisions. If it's really clinical or service, it's you, but with the clinical service line really pushing it. And if it's business directed, it's going to be the business people, but again, with the cost benefit analysis, whether you can support it and so forth.
Correct.
Chuck, could you add on to the answer on who makes the decision? And then Wyatt, love to hear your perspective as someone who works with and ultimately Lenovo Health, Intel, Lenovo directly does business directly with health systems. Who are you working with at health systems? But Chuck, your answer first.
So very, very similar to Bruce. We have a very strong IT governance. So a lot of the business clinical needs go through there. It's all mostly C-suite people involved in that. So we can get into pretty high cost areas based on the different projects that are out there. And we've set it up that way. And I've actually the governance that we use, it's run by the CMO, and then also our who's the head of quality, because we wanted a clinical slant on it. So the CIO, I'm involved, but I don't chair it.
Thank you. Wyatt, some of your thoughts on how this has evolved over the last several years in terms of who really decides on or who's involved in technology spend at systems.
Right. From our point of view, it really is beginning to depend very much on the technology itself. What purpose does it serve inside the organization? And outside of traditional systems infrastructure and user compute, devices and technologies such as remote patient monitoring platforms, augmented and virtual reality, and IoT really begin to involve many different stakeholders inside the organization that come at it from a particularly clinical perspective. And that is not only extremely valuable to the process, it represents kind of the shift in organization, how we're applying some of these technologies and the intent of lifecycle for the technologies inside the organizations and the patient care delivery process as well.
Thank you. I've got another great question from our audience. And Bruce, I'll start with you again because it's an issue you had discussed a little bit. It's the resistance of patients to participate in telehealth and telemedicine. Is that how much do you see that today, and how do you break down that resistance? And then Chuck, I'd love your thoughts on it too, and Wyatt, if you want to comment too. And again, just given that we've got 5-6 minutes left, short, quick answers to stay. What do you see out there, and are there things you could do to reduce that resistance?
Well, it depends on the particular application and patient population. We actually haven't really seen resistance, and a lot of what we're doing is being driven by what our patients need and are looking for. But if we did run into real resistance, we wouldn't necessarily require that patients participate in a program. They would really need to sign up for it. Partly, we would educate folks to understand what the benefits and the values are, and often we just don't work with patients, but we also need to work with their families, because the technology piece is just a part of the care process, and we would always make sure that we retain that human contact, particularly between our patients and our providers.
I mean, it seems like some things, and Chuck, I'll ask you to comment on this as a variation of the question, some things patients just really want, and so they don't resist at all. Other things, when systems try and connect their patients into the System Connect system and be logged in as a regular patient of the system, there the buy-in from patients seems to be less. Some of your thoughts on how you break down resistance to get patients more engaged in ways with you that the system would like. Any thoughts on that, Chuck?
Sure. Well, we have a big psych telehealth program. That's where we started. And the way we do it is the initial consult, initial meeting with the patient is face-to-face. You don't start off with the telehealth visit in that type of area. So once they see their provider, they get comfortable, and then you can start the telehealth program depending on what's happening in that particular patient's life. And actually, if you've ever been to Southern California and the traffic down here, it's very much, we don't have the type of resistance you might have in some other areas that people can stay home. But the key is having that face-to-face up front and getting that that comfortability before you move into the virtual aspects.
Let me ask you a question. It seems like in certain areas, patients really want this. It's just exactly what you talked about. The traffic makes it brutal to go see somebody. If they could do it by phone, they'd much prefer it. In other areas, it seems like the system prefers it, but the patient doesn't necessarily want it. Is that a fair statement, or is that you don't really see that?
For us, no, we don't. No, we don't really see that. I mean, the physicians like it as well. I mean, we're working on, as long as you're getting reimbursed, you've got to have that reimbursement aspect to it. If you got that all worked out, our physicians love it because, it's convenient for them as well. They can, definitely see more patients and keep track of their patient population.
Yeah, I would absolutely agree with that and agree with you. Sure.
Thank you very much. Wyatt, let me ask you a couple of questions.
Especially younger patients. I mean, that's younger patients.
The younger patients all want it, right? More and more. I mean, that's where they've seen their whole life at. And so
definitely the millennials are all over it. Yeah, that's how they want all their patient care that way. I think if they could get surgery that way, they would do it.
Right, exactly. Wyatt, let me ask you a question. There's a question about AR and VR and the difference in healthcare. I don't know if you've seen this question online from one of our attendees. It says, please define AR and VR and the difference in healthcare. Is that something you could comment on, Wyatt, or is that?
Absolutely, yeah. So we as an organization really see both augmented and virtual reality as serving very unique roles within healthcare, and the opportunity for both technologies to be really quite vast. One, unfortunately, kind of leading into the other, however. So as we think about virtual reality technologies, we're really thinking about immersive experiences, sensory isolation, which is fantastic in particular for diversion, distraction, self-efficacy, mental and behavioral health for the patient while they're inside the facilities. For pain management in particular, there have been a number of worldwide studies that show 30, 40, 50% reduction of pain medication chemical dependency as well associated with the use of virtual reality to control pain. And then as we move beyond kind of a patient-facing context for virtual reality, the opportunity for simulation in environments, training knowledge workers, not necessarily only on new procedures and new techniques inside of the organization, but be able to train and test compliance with that understanding as well. It's a very effective platform for not only communicating information, but then actually quantifying the level of comprehension and the ability to apply that information. When we move beyond that fully immersive experience, we get to augmented reality, which combines many of the features that you would find of digital objects with respect to communicating information, visualizing data, and allowing an integration of systems with the electronic health record, with an IoT environment, and in particular with AI and machine learning in a number of different flavors to be able to deliver insights to providers, to patients in real time in a very on-demand and systematic way, such that the value of technology can be realized in real time, as opposed to delivery of those insights after the fact and trying to then re-engage with patients or with the systems that you're trying to influence.
Thank you very much. I want to do this. We have so many questions, and I know we can go on for a long time. But I also know that we'll lose our audience at the end of the 60-minute period, and people will start to dial off. And right now, between Dr. Metz, Chuck, and yourself, Wyatt, you've done a wonderful job because I've seen very few of our audience members dial off. And so rather than continuing, I'd rather have us end the webinar at 1 o'clock on the dot while people are still thrilled with the content before we start to lose people. So I want to do this. I want to spend a moment thanking first Lenovo Health and Intel for their sponsorship of the webinar. Then I want to thank our three panelists, Dr. Bruce Metz, Chuck Podesta, and Wyatt Yelverton. I want to thank all three of you very, very much for your participation. Just Yelverson, thank you so much. And then our audience, of course, for spending time with us and hopefully gaining some knowledge of how IT is being used to help encourage and foster innovation in systems and some of the wonderful things that you're all doing. So thank you, folks, very, very much. And I think we'll call it an end there, and thank everybody. Chuck, Wyatt, Bruce, we'll visit with you again shortly. Thank you, folks.
Sounds good. Thank you.
Bye-bye.
Bye-bye. Thanks.
Thank you.